Hello and welcome to this lecture in the series Trauma and Orthopaedics for medical students, aiming to cover the core topics for the medical licensing assessment. This talk is on disorders of the hip and knee. As with all of the previous talks, we've aimed to try to map it to the key items in the medical licensing assessment, and you can see which topics this lecture covers. This lecture will cover topics in both the hip and the knee, and you can see highlighted in purple here that hip osteoarthritis, total hip replacement, and the fractures of the neck of femur are the topics you really need to concentrate on. And remember that the neck of femur fractures have been covered in the fractures lecture. With regards to the knee, the key topics are osteoarthritis and arthroplasty, as well as meniscal tears and ACL tears. The other topics are there for your interest, but they are not essential for the MLA. The majority of arthritis that we see in the hip is osteoarthritis, but do remember that any of the arthritic conditions, so psoriatic, rheumatoid, etc., can affect the hip. And this is the basic definition of osteoarthritis. So it's a degenerative disease causing progressive loss of articular cartilage of both the femoral head and the acetabulum. As with all osteoarthritis, there are risk factors which are both modifiable and non-modifiable. So as you would expect, the non-modifiable are things like gender, age, genetics, and the modifiable ones are trauma, heavy physical work, and high impact sporting activities. The symptoms, as you'd expect, are predominantly pain to the point where it starts to limit function. There will be a decreased walking distance. There may well be pain at rest, and particularly at night. Patient may well complain of stiffness, particularly when trying to flex to sit down, and there may be a locking or catching feeling, which can be more of an instability type feeling, although the hip is not dislocating. The physical examination includes both inspection, looking at the body habitus, looking at the patient's gait, which you're expecting to be antalgic, but be aware of a leg length discrepancy, and make sure that you look for scars. Have they had previous surgery? Remember to look at the back, because back pain and radicular pain can refer to the hip, and equally look at the knee, because knee pain can refer to the hip. You look at the range of motion, particularly a lack of full flexion and internal rotation, and remember to do a neurovascular examination at the end. The plain X-ray is the standard first-line investigation, and you should see the classic features of osteoarthritis, with a loss of joint space, with sclerosis, particularly the upper part of the femoral head. There may well be cysts, and there will be osteophytes, although these can sometimes be a bit hard to see. If you want, you can classify the degree of arthritis, and we've presented it here, but you don't need to worry about this, particularly for the MLA. The treatment is the same as treatment for all arthritic conditions, so you can start with non-operative, which is analgesia. You may find that a walking stick is enough to offload the joint and reduce pain. Simple things like weight loss, activity modification, and exercise combined with physical therapy can strengthen the joint, and that can help. And occasionally corticosteroid injections can be used, but these tend to be rather short-lived, and there's an increased risk of infection when you go on to do a joint replacement, so these are used with caution. When you move on to the operative management, in a younger patient with limited disease, it may be appropriate to do an arthroscopic debridement, and sometimes you can do osteotomies to realign deformity and offload parts of the joint. But probably the most common operation done for hip arthritis is hip replacement. And this can be a total hip replacement, which is the most common, or occasionally hip resurfacing, although this has slightly fallen out of favour more recently. So in a classic total hip replacement, the femoral neck is cut and the head removed. The acetabulum is then reamed to take a socket, and this can be an all polyethylene socket or it can be a metal back with a polyethylene liner. And then a stem is inserted into the shaft of the femur, and this can either be inserted with a cement grout or can be uncemented. And then a head is fitted which fits into the acetabulum, and there are a number of different bearing surfaces for this, including cobalt chrome and ceramic. It is worth knowing a little bit about the risks of total hip replacement because it is such a common operation, and pretty well whatever branch of medicine you go into, you will come across patients who have had it. So be aware of the more common ones and the less common but serious ones such as dislocation, deep infection and nerve injury. We'll now move on to just remind you briefly about the fractured neck of femur, because it is important. A large number of patients will sustain a fractured neck of femur and it can be life-changing. It is covered in more detail in the fractures lecture, but this is just a recap for you. So we worry because of the blood supply to the femoral head, and this comes up in an anastomosis that goes around the neck of the femur just between the two trochanters, and then all the blood supply to the head comes off that. Therefore, if you fracture inside the anastomosis, so in the neck itself, you risk avascular necrosis of the femoral head. The mechanism, very simply, is a fall, classically in the older patient, often with comorbidities. In the younger patient, it tends to be a high energy, either that's a fall from a great height or a motor vehicle accident. The presentation is fairly simple. They're unable to walk. The leg will be shortened, adducted and externally rotated. And if you roll the hip, it'll be painful. With the intracapsular fracture, there are classically 4 types, but most of the time we look at them as either undisplaced or displaced. This is what it looks like on an X-ray, and if you follow the cortex of the femur up, you can see that there's a break and that the head is displaced, or the femur really is displaced on the head. The other type of fracture is the extracapsular fracture. So this is a fracture between the trochanters. So this is outside the blood supply, and you can see on this X-ray here that there is actually a fracture of the lesser trochanter, and it runs up to the greater trochanter, and there is more femoral neck. The treatment of these is discussed in the fractures lecture, and you should have a look at that at some point. The final thing that we'll touch on with the hip is trochanteric bursitis, as this is one of the differentials for pain around the hip. And this is classically pain over the lateral side of the hip caused by a repetitive, probably quite minor trauma, usually secondary to iliotibial band tracking. The clinical examination of patients with trochanteric bursitis is very simple, as the patient will localize the pain to the greater trochanter and it will be tended to palpation. The treatment in the majority of cases is non-operative, with non-steroidals, anti-inflammatories and stretching, and rarely cortisone injections. Occasionally surgery is required, and this can either be an open or an arthroscopic bursectomy, but this is less frequently done. If we move on to knee arthritis, the definition is really very similar to that for the hip, with it being a degenerative condition causing progressive articular cartilage loss, and this can affect not only the tibia and the femur, but the underside of the patella as well. As with the hip and all other arthritis, there are risk factors which are both modifiable and non-modifiable, and as with the hip, the modifiable ones are fairly simple. So this is trauma, occupational risks, particularly with loading the knee, being heavy and some metabolic syndromes, and the non-modifiable ones, as before, are gender, age, genetics and race. The presentation should be fairly self-evident. The patient will describe function-limiting knee pain with a reduced walking distance as a consequence of pain, quite often night pain. There'll be swelling in the knee often, which you don't see in the hip. There will be a reduced range of motion, and there may well be more mechanical symptoms than you get in the hip, with catching and locking. The clinical examination follows the same pattern as all orthopaedic exams. Initially the inspection, which is general, looking at the body habitus, the gait and the limb alignment. Have they got geniverum, genivalgum? So are they going to be loading the joint abnormally? Is there an effusion? Are there any scars? Are these arthroscopic scars? What's happening in the hip? What's happening at the foot and ankle? And then the range of motion. Typically they'll have a lack of full flexion and extension. You need to assess the ligaments, are they stable? And then have a look at the neurovascular structures as well. Particularly in the knee, if you're considering joint replacement, think about the blood supply to the foot. As with all joints, the investigation of choice is an X-ray, looking at the joint space both on the medial and the lateral side, the joint space between the patella and the femur, and particularly in the AP view, this is done in 30 degrees of flexion and ideally weight bearing, as this will show things up much more clearly. As with the hip and all joints, there's a grading system. We present it here for you to be aware of, but you certainly don't need to know it for finals. The treatment, as with all, is non-operative to start with, anti-inflammatories. Sometimes braces can be used to offload if the arthritis is more on one side than the other. Think about weight loss, activity modification, physiotherapy and exercise to strengthen the muscles around the joint, and as before, steroid injections, but again they can increase the risk of infection if you put a joint replacement in, so they need to be considered carefully. Operatively, in some patients it's appropriate, if the symptoms are more mechanical than pain, to do an arthroscopic debridement, remove loose bodies and flaps of tissue. In the younger patient, if the arthritis isn't too bad and they have bad mechanical alignment, it's possible to effectively break the bone surgically and realign the leg, and this can delay the progression of arthritis and delay the need for a total knee replacement, which is the final option. Although more recently, if the arthritis is only in one compartment, you can think about doing what's called a unicompartmental knee replacement, and this can delay the need for a total knee replacement. Here we can see an AP and a lateral view of a typical total knee replacement with the metal resurfacing of the femur and effectively a tibial tray with some sort of peg to stabilize it in the tibia, and then in between the two there'll be a polyethylene insert. On the right hand side of the slide you can see a unicompartmental knee replacement on the medial side of the knee. As you can see on the X-ray next to it, that actually only the medial side is affected. Moving on to the soft tissues, the first condition is meniscal tears. So the menisci are two C-shaped fiber cartilage structures found in the knee between the tibia and the femur. The lateral meniscus is slightly wider and has a greater diameter than the medial meniscus, and the lateral meniscus is not attached to the lateral collateral ligament, so it is a little bit more mobile. They're important as they are not only shock absorbers, but they increase the effective contact area between the femur and the tibia, reducing point loading on the cartilage. When the meniscus is injured, the patient may describe a tearing or a ripping sensation in the knee with a sudden pain. Classically, the knee will swell, but it'll swell slowly over several hours. Sometimes, if there's a large flap or what's called a bucket handle tear, this can jam up in the joint, which means the joint is then locked in flexion and the patient may not be able to fully straighten it. The patient may well have pain and localize this either to the medial or the lateral side, although this is not always necessarily the site of the problem. As the swelling settles down, they may describe mechanical symptoms of locking or catching, particularly when they squat or when they come out of their squat. Clinical examination may reveal joint line tenderness, but this isn't a guarantee, and if the knee is particularly irritable or the injury is acute, there will be an effusion, full stop. There are a number of tests you can do to elicit symptoms. However, none of these are particularly reliable and are often not done in clinical practice. If you're in any doubt about the diagnosis of a symptomatic meniscal tear, then an MRI is the treatment of choice, and you can go through all of the views. You can certainly then look for ligament injuries, and you will pick up meniscal tears quite nicely on an MRI. The treatment options are, as you would expect, non-operative or operative. The non-operative treatments are rest and anti-inflammatories, with physiotherapy if the knee is particularly weak, and for the vast majority of people the symptoms will settle down and no further intervention is required. If the patient continues to be symptomatic, then operative treatment is appropriate, and there are a number of things that you can do. In the older patient and the smaller tear, it may be appropriate just to trim away the damaged tissue. The problem here is that you are removing some of the shock absorber, and if you take away too much meniscus, and particularly if you do this in a younger patient, then you increase your risk of arthritis quite significantly. Therefore, it may be appropriate to undertake a meniscal repair, particularly in the younger patient with a more peripheral tear, and on occasion, but this is planned, a meniscal transplant if you've had to take the whole of the meniscus out in a younger patient. But again, these are less common. If we now look at ligamentous injuries around the knee, we just need to consider the main movements of the knee, which are flexion, extension, rotation, both lateral and medial. There are therefore ligaments which contain all of these. There's the anterior cruciate, the posterior cruciate, and the medial and the lateral collateral ligaments. The ones we really need to concentrate on for our purposes are the anterior and the posterior cruciate ligaments. So the anterior cruciate is the primary restraint to anterior translation of the tibia on the femur, and it also has a contribution to rotational stability of the knee. If the anterior cruciate is injured, and this is typically in a rotational deceleration mechanism, so this is somebody running who plants their foot hard and then twists around it, the patient will describe a pop with a deep pain and immediate swelling, and this is a hemarthrosis, so there's blood in the joint. If they're playing sports, they will have to stop. They'll describe a pain all around the knee, and once all of this is settled down, they may well have a feeling of instability, particularly if they change direction, and be unable to return to their sport. The clinical examination follows the same as all of the other joints. You start with inspection, looking for an effusion, looking for the ability to extend or flex. This is then examined formally, and you then look for the other injuries. So do they have a meniscal tear? Do they have collateral ligament tears? And then there are three things that you can do to directly test the anterior cruciate. These are the anterior draw, the Lachman's, and the pivot shift, although the pivot shift is usually done under an anaesthetic. And remember just to check the neurovascular status, particularly if you're going to consider operating on this patient. The imaging is exactly the same as all of the other imaging. You start with a plain X-ray, as this may identify fractures, particularly these funny little things like a Sigon fracture, which certainly points you in the right direction if you see one, but they're not always present. And then an MRI, which will show you the presence of not only the cruciate ligament injury, but the presence of any other injuries which you may need to be aware of, such as a meniscal tear. Treatment can be non-operative or operative, and not everybody who has an ACL injury needs to have surgery. If you are not undertaking sports, or you don't undertake sports in which you have to pivot and change direction frequently, or the knee just feels stable, then you don't have to have an operation and physiotherapy will do well. If you feel unstable or your sports require it, then sometimes it's possible to repair the damaged tendon, but more often it needs to be reconstructed or replaced, and this is done using a hamstring or a quadriceps tendon, or occasionally an allograft. You don't need to know too much about posterior cruciate ligament injuries, but you just need to be aware that this is the primary restraint to the tibia going backwards on the femur, but it can present in a very similar way to the ACL. These injuries are much more likely with high energy trauma, such as the dashboard injuries, where the tibia is driven backwards. The patient may have knee pain, which is quite often deep and posterior. They may describe instability. The clinical examination follows the same pattern as all of the others, but in this case, when you put them into the 90-degree flexion position, the tibia will sag backwards on the femur, as you can see in these x-rays, and you do the equivalent of the anterior draw, but on this occasion the knee will go backwards, so it's a posterior draw test rather than an anterior. And there are other things you can do as well, but these are more specialized and you don't need to be aware of them at this stage. Imaging, again, you get the plain x-ray just to make sure there aren't any fractures, particularly in the higher energy injuries, and the mainstay of investigation is going to be the MRI, and you can see here on this lateral view that the PCL is attached to the femur and then becomes very indistinct just as it approaches the tibia. Treatment is non-operative if the knee is stable, strengthening the knee with physiotherapy. Operatively, it's a slightly more complicated operation as the ligament goes from the back of the tibia to the front of the femur in the middle. And actually the way of doing this most of the time is to start at the front of the tibia and drill this sort of slightly zigzag approach, which is technically more difficult than an ACL. We're now going to look at the extensor mechanism of the knee. This is the coupling of the quadriceps, the patellar tendon, and the patella in the middle. This is not stuff that is essential for the MLA, but it is useful to be aware of it, as these injuries are quite common. If we start at the top with the quadriceps, this is classically a traumatic injury to the quadriceps tendon as it inserts into the superior pole of the patella. Although these injuries present as an acute event, and there may well be a good explanation for an acute injury, there is quite often a preceding history of some discomfort suggesting that tendinopathy was the underlying cause. The patient will describe pain above the superior pole of the patella with swelling. They'll have difficulty weight bearing and describe being unable to straighten the leg properly. The clinical examination is often quite obvious. There'll be tenderness at the superior pole. There's often a palpable defect just above the superior pole of the patella. And if there is a complete rupture, the patient will be unable to do a straight leg raise, and they will certainly be profoundly weak if they're trying to extend the leg against any resistance. As with any acute injury, the first thing to do is to get an X-ray, and you may see a hemarthrosis. But what you will see on the lateral is a thing called patella baja. So this is where the patella drops relative to where it should be, because you've no longer got the quadriceps tendon pulling it back up. Confirming the diagnosis, because it is a soft tissue injury, is MRI or ultrasound, whichever is most available, and this will help with potential surgical planning. The treatment can be non-operative or operative, and if the injury is only partial and the patient has some extensor function, then you can treat this in a brace, in extension, for quite a long period of time. More commonly, these are treated surgically, and you then have to reattach the tendon to the patella. This is often done with stitches that go all the way through the patella, and then the tendon can be pulled down firmly. There's then quite a long, slow process of rehabilitation, often with the leg in extension for several weeks before they're braced, and it can be 6 to 9 months before they're back to sports. Moving down the mechanism, the patella can fracture. This can either be due to a direct blow, such as a fall on the patella, or a sudden forced rapid contraction, overloading the patella and causing effectively a stress fracture. The history, as I've described, is usually fairly self-evident, with pain and immediate swelling and usually an inability to weight bear being the presenting symptoms. The inspection may show lacerations or abrasions if there has been a direct blow to the patella, and you need to be aware of an open fracture in these cases. There may well be a palpable patellar defect and a significant hemarthrosis. As you'd expect, there'll be an inability to perform a straight leg raise. Investigations start with the plain X-ray, and this may well give you all the information you need, as you'll see displacement of the fracture fragments, hopefully quite clearly. If it's more comminuted or undisplaced, then a CT scan may be useful to show you exactly what the nature of the fracture is. If the fracture is undisplaced or the patient's not able to tolerate surgery, then it may be appropriate to manage these non-operatively with the knee in extension and then gently worked into a knee brace. This can take a very long time and is often not tolerated well by the patient, and if you're not careful, they're left with a lag and a weak knee, which can be very disabling. More commonly, these are treated operatively with open reduction and internal fixation. There are a number of ways of doing this, and all techniques have their merits. Very, very rarely, in some patients, it may be appropriate to remove the fragments of the patella and then reattach the soft tissues, but this is pretty rare. As we move down the leg, the next structure in line is the patellar tendon, and this can rupture either as an acute event or quite commonly on the background of previous tendinopathy. As before, the patient will give you quite a clear history of what happened, as it is an acute event. They'll describe pain below the patella with immediate swelling and difficulty in weight bearing. On clinical examination, the patella will be riding high because you've lost the tethering mechanism of the patellar tendon. There will be an effusion and localized tenderness with a palpable gap below the patella. The patient will have a reduced active range of motion and will be unable to perform an active straight leg raise or hold the leg if you bring it out into full extension. X-rays are taken to confirm that there's no other fracture, and in the same way that when you had a quadriceps rupture there was patella baja, in this case with the patellar tendon rupture there is patella alta, with the patella riding up and overlying the distal femur. MRI and ultrasound can confirm the nature of the tendon tear. Again, these can be treated non-operatively if there's a partial tear or the patient can't tolerate surgery, but like the patella fractures, this leaves the patient often with significant weakness and they struggle with gait. More commonly, these are repaired with either direct repair of the tendon through the patella, just like the equivalent with the quadriceps, or in the more chronic cases it may be necessary to use some form of reconstruction with an augment using a hamstring tendon or some such. And finally, one last thing for you to be aware of, and this is the Baker's cyst. This is a fluid-filled sac that forms in the popliteal fossa in the back of the knee. The patients will describe a fullness or a tightness in the back of the knee, and occasionally they may present following a rupture of the Baker's cyst, which can be confused potentially with a DVT. The clinical examination reveals a swelling that is fluctuant in the back of the knee, and there may be other pathologies such as arthritis going on. The investigations often aren't necessary if it's small, but again, plain X-rays may pick up arthritis or something like that, and if you're particularly worried, then an MRI will help. The treatment is advice and rest, reduction in activity, as these will swell more the more exercise you do. Occasionally, if they're a real problem, you can go in and treat the underlying cause, whether it's the arthritis or a meniscal tear. And very rarely you can formally decompress the cyst and open up the neck of it, but this is less common as well. And that brings us to the end of this talk on conditions affecting the hip and the knee. As you can see, there are not a huge number of conditions that you need to worry about, but you certainly need to know the ones that I highlighted at the beginning in some detail, and you should have some knowledge of the other ones. We hope you found this useful and that you enjoy the other talks in the series.